that I think that viral load monitoring is clearly associated with it, meaning if we would be able to monitor virologically close, or even in general, as much more viral load testing as we can do, we could hopefully identify those patients earlier when they still have only M184V, and then the impact will be less. Phenotype, my main answer is cost. These are usually much more expensive tests, and they usually are needed for patients who are much more treatment experienced, that have much more treatment drug resistance mutations, and therefore the interpretation might be more difficult. And though there are emerging tests that try to incorporate phenotypic resistance at a lower cost, this is still, I would say, not the case. So I think when we talk about resistance, genotyping is still the way to go.
Thank you very much. We will have questions from the floor.
We have started a program, Indian program of NACO with stavudine-based or zidovudine-based regimes almost 10 years back now, on 12 years now. So they are failing now. So, but there is, we have shown the study only for the M84V or K103. So there is no TAMS studies over here. What about TAMS in the as mutations in anywhere in the? Is there a study TAMS mutations?
So you're asking if TAMs occur or if they are important?
Or if any study doing the TAMs, because there's only K103 or M84V, 10% and 50% like that, but nowhere is the TAMs are in the resistant testings.
So if I understood you correctly, you're asking about D4T based treatment, is that right?
D4T or Z, AZT.
Or AZT, right. Yeah. So yes, TAMs do occur in D4T or AZT-based treatment, and if you wait long enough, you can accumulate enough TAMs that will even impact tenofovir. That's rare, but it does occur. So yes, studies that are on D4T-based or AZT treatment show accumulation of TAMs, and the longer they wait, the worse. I hope that answers your question.
Any studies are there on the TAMs? That's a studies on TAMs.
There are multiple studies. Every study that would have an AZT or D4T based treatment and look at failure and resistance will have accumulation of TAMs. These are the most common mutations that accumulate when you have D4T or AZT based treatment. So there are multiple studies, including from Kenya. I think I showed one from the past year on AZT based from Chennai, but any study you would look at where this is the baseline regimen would have accumulation of TAMs. Perhaps it would be together with NNRTI as well as with M184V, and perhaps they occur a little bit later and at lower frequencies, but they do occur.
Basically, one of the reasons for moving away from AZT-based regimen was to TDF was the reason that if you have accumulated TAMs, you may have K65 or also, and you may not really respond well to tenofovir. That is why we have moved away from a AZT-based regimen to a tenofovir-based regimen.
Some laboratories are giving us virtual phenotype resistance reports. What is your comment on that? How reliable is it?
Virtual phenotype. That's what you're asking about? Personally, I don't have a lot of experience with it. There are not too many studies, as far as I know, that have looked at virtual phenotype compared to real phenotypes. So my experience is limited. I know that a lot of European centers do use virtual phenotype, and they have good experience with it. I would say that from an Indian perspective context, the amount of subtype C infected people in general and Indian specific subtype C infected people that are in the database that is sort of the feeding information for the virtual phenotype are low. So that's but that's a limitation to think about virtual phenotype in the Indian context. But in the European context, like I mentioned, which the majority of the data are coming from, I think there are centers there that use it.
I don't see any other questions, but just to update, this issue is being taken seriously now. In India also, WHO has now supported NACO to actually write and clear a proposal and get the funding for drug resistance surveillance in India, in which we'll be doing PDR, and ADR12 and ADR48, and 400 samples will be selected at 40 sites based on the WHO sampling strategy, and Dr. Ganga Khitkar at NARI will be conducting this study. And once we have the baseline surveillance, then it will actually decide on the individual drug resistance testing before initiation or initiation of second line or third line. I think this will be the last question.
Question is to Dr. McLeod. You know, when we get our genotype resistance testing done from Vyarji Care Chennai, and it costs us about rupees 6,000 for NRTIs and NNRTIs, and rupees 8,000 for the PIs. So when you talked about Panda, you know, there seem to be so many advantages, but when it comes to cost, it's about the same that we are paying now. Just a comment.
This microphone on? Yep. 1,000 rupees, I believe, is $150. Would that be right? So, yeah.
No, $100 would be equal to 6,500 rupees. It's about 65 rupees to a dollar? 67 rupees to a dollar. So $100 is equal to 6,700 rupees.
Okay, that's one.
Huh?
So it's about $300, $400 maybe?
Yeah, it costs us $100 to do NRTI and NNRTI
Okay,
resistance testing today.
Yeah, $100. We would definitely be under $100. $100 is our upper threshold. The benefit being that you could possibly, if you have the equipment, do it at point of care, so you're not having to wait for resistance tests to be returned. Panda is also much more sensitive than Sanger sequencing, so you will detect resistance earlier. So those are the major benefits, and being able to do 24 patients at a time as well.
But in India, the cost factor is the most important.
Yeah, no, absolutely. If the patient is the payer, then...
The cost comes down with volumes also.
Yes, exactly. Yeah.
Thank you, both the speakers and the audience, for the active participation. And just a closing remark as a microbiologist, that resistance testing must be made widely available along with viral loads. And another point is all mutations that we detect in the lab by the molecular assays need not be interpreted as clinically relevant. And thirdly, there is a need for simplified and cost-effective ways of detecting resistance which is clinically relevant. Thank you.
Thank you, speakers and co-chairs. I would like... And Dr. B.B. Rewari to please